Alright, in this lesson we are going to be discussing Argatroban. And just a quick background on this medication, so Argatroban was actually first approved in Japan in 1990, so it hasn't been around all that long, and it is used as an anticoagulant for chronic arterial occlusion. In 1996, approval was granted for an additional indication such as acute cerebral thrombosis and for the treatment of hemodialysis patients who are antithrombin deficient. So this is that cofactor that's required to make heparin effective. It was not actually FDA approved until 2000 when it received approval for the use in HIT, and then in 2002 for the use in patients undergoing PCI who have HIT or are at risk of it. Now what this drug is it's actually a drug that interferes with the normal coagulation process by interfering with that clotting cascade and directly inhibiting thrombin formation. So again, I'll have a future lesson talking about, or it might actually be out already by the time I do this lesson, talking about the clotting cascade, so hopefully it will make more sense. But what it does is it actually reversibly binds to thrombin to inactivate it and then prevent fibrin formation and platelet aggregation. So let's talk about some of the reasons in which we would use it. So like I talked about the treatment of thrombosis in a patient who has heparin-induced thrombocytopenia or HIT. So this is probably one of the most common cases that we'll use it. We can use it for anticoagulation in patients with or who are at high risk of HIT and if they're needing that cath in the cath lab, so a PCI. And then we can use it instead of heparin when the heparin dose is continuing to be increased, but the lab values are not actually within therapeutic range despite these increased doses. Since this is a direct thrombin inhibitor, it does not require a cofactor like heparin to be effective, which could potentially limit at the higher end ranges the efficacy of heparin. Now, some cases in which we wouldn't want to use this for a patient, so obviously those who have an overt risk of bleeding or have some sort of hypersensitivity to the drug. We do want to use it cautiously in patients with hepatic disease or conditions that increase the risk of hemorrhage, such as severe hypertension. We do want to use it cautiously in patients with recent lumbar puncture, spinal anesthesia, major surgery, history of hematologic conditions that do cause increased bleeding tendencies, as well as history of GI ulcers. And then make sure that we use this cautiously in patients who are quote-unquote critically ill because they may actually require a reduced dose of this medication. Now for some of our adverse effects of this, so we have our cerebral vascular accident, CVA. Hemorrhage would obviously be an adverse effect. Potentially AFib, VTAC, and bradycardia. GI bleeding, so again, this would be in the risk of hemorrhage, hematuria, bleeding in general, hemoptysis. So really most of these things are focused around the bleeding risk for the patient. As far as the drug itself though, some of the common concentrations that we can see it in 1 milligram per ml in 50 ml vials. We can see it 100 milligrams per ml in 2.5 ml vials. And then we're often going to dilute this either in normal saline, 5% dextrose, or lactated ringer to get its final concentration of 1 milligram per ml. Now, for our dosing, IV infusion is how we're going to be using this. Our initial dose typically is around 2 mics per kilogram per minute, and the dose is going to be adjusted until we have the desired effect that is seen in our anticoagulation. Our max dose for this medication is going to be 10 mics per kilogram per minute. As far as the pharmacokinetics go, when we inject it IV, it does have a rapid onset of action. It is partially excreted in the urine, as well as through something called proteolytic cleavage. Not important to know, but basically it's just the breakdown of the bonds between amino acids on the protein, thus changes the structure of the drug. IV administration, like I said, rapid onset, peaks within 1 to 3 hours, and then the duration is about the duration of the infusion. Important to know though is that there is no antidote for this medication. Now for some of the things to consider caring for these patients at the bedside, again as always make sure you're assessing for those allergies, avoiding any hypersensitivity reactions. You do want to screen them for conditions where they could have exacerbation or increased bleeding tendencies. So we do want to evaluate the actual therapeutic effects. So again, our APTT is used to evaluate this one. And this is going to be used to adjust that dose of the Argatroban. Typically, we're going to have a specific APTT goal ordered by the provider, and then your hospital hopefully has a protocol for what those adjustments are based on your APTT as far as increasing or decreasing your rate. We can also use activated clotting time or ACT and here our therapeutic range is 300 to 450 seconds, at least specifically for procedural uses. Again, this could be decreased if we're doing this medication on a longer term basis, maybe greater than 200 at that point. Again, just like with our other anticoagulants, we want to make sure we're regularly assessing our patient for signs of bleeding or blood loss. So again, the petechiae, bleeding gums, bruises, dark-colored stools, dark-colored urine. If we do notice any of this, we do need to reach out to that provider and figure out what they're wanting to do, whether it's adjusting rates or stopping the medication. We do want to monitor CBC lab values, as a decrease in hemoglobin could be an indication that there is bleeding going on if we don't have any overt signs of bleeding. Again, make sure we establish bleeding precautions and try to prevent the patient from having any injury. Use safety measures, so electric razors versus manual razors, to cut down on that risk of bleeding. And again, just important to know, we don't have any specific antidote for Argatroban. So that was our review of Argatroban. Again, hopefully some good information for you guys, and hopefully you guys enjoyed it. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.